All right, everyone, welcome. Thank you for joining us this evening. My name is John Ahern. I'm the Associate Director for Graduate Programs here at the Woods College of Advancing Studies. It's my pleasure to be with you tonight. We have a great panel assembled to speak about IT outages in healthcare and how to best address those outages when they occur. I'll go ahead and introduce my colleague, Dr. Basel Tarab. He wears a couple different hats for us. So here at BC, he is a faculty member in our Masters of Healthcare Administration. Should have mentioned at the top, this program is sponsored in partnership with our Master of Healthcare Administration and the leadership of the Winchester Hospital. Dr. Tarab also works at the Winchester Hospital as the Director for Patient Experience. So Basel, I'll turn the floor over to you to introduce the panel.
Thank you, John. Thank you so much. I want to start by saying good evening to everyone, and thank you all for joining us today for the panel discussion on navigating IT outages and healthcare, ensuring continuity of care and patient safety. As you all know, this summer's major IT outage, including those involving CrowdStrike and Microsoft, demonstrated just how vulnerable the healthcare system can be. In just a few hours, we saw flights grounded, televisions, stations taking off the air, and critically, this is what we are concerned more about, is that hospital systems got disrupted. So what does that mean to healthcare? And how do hospitals maintain continuity of care and ensure patient safety when the unexpected happens? Today, we will hear from a group of healthcare leaders who will share their insight and preparing for the responding to IT outages. And I'm very excited to be joined by this esteemed panel from Beth Israel Lahey Health, Winchester Hospital leaders. And I look forward to a rich and practical discussions. So let's dive in, and I'm going to ask everyone to send their questions, and the panel will respond to it. We will answer these questions. I'm going to start by briefly introducing the panelists. I'm honored to introduce Mr. Matt Hinkle. Matt currently serves as the Chief Operating Officer at Winchester Hospital, where he has been leading operational initiatives since early 2024. With over a decade of leadership experience in healthcare, including previous roles as a Market Chief Operating Officer at Piedmont Medical Center and Vice President of Operations at the Regional Medical Center in South Carolina, Matt brings a wealth of expertise in hospital management and patient care services. Matt obtained his nursing degree from Centera College of Health Sciences and his master's degree in health administration and management from Bellevue University. The second panelist on today's panel is Mr. Sage Weichel. Sage is the Director of Emergency Management at Beth Israel Lahey Health and Winchester Hospital, where he has been leading emergency preparedness initiatives since October 21. With a strong background in crisis management and project leadership, Sage has held various roles in the emergency management at Beth Israel Deaconess Medical Center and brings a wealth of expertise in strategic planning, interdisciplinary coordination, and training development. I actually witnessed that firsthand yesterday. We had the drill with him, so thank you, Sage, for that. Sage has earned his master's in degree in healthcare emergency management from Boston University School of Medicine. We also have Julie Martineau. Julie is the Manager of Nursing Informatics at Winchester Hospital. She is an experienced nurse with a diverse background. She started her career as a bedside nurse before joining the informatics team. Julie obtained her BSN degree from St. Anselm's College and her Master's of Science in Nursing Leadership from Western Governors University. And last but not least, Brandon LaRoche. Brandon currently serves as the Associate Chief Nursing Officer at Winchester Hospital, where he has been leading nursing operations since November 2021, with extensive experience in clinical leadership roles, including his previous roles as a clinical nurse director at Tufts Medical Center and nursing director at York Hospital. Brandon holds a Doctor of Nursing Practice, DNP, from Yale University, specializing in healthcare leadership, system, and policy. With that, I'm going to start by asking my first question to Matt, and really I will be focusing on the scope and impact of the IT outage on the overall healthcare system. Matt, If you would please say a few things, or answer what are the broad impacts of IT outages on hospital operations, and how do they affect patient care delivery? How, as you see it as a chief operating officer?
Thanks, Basil, and thanks for having me, everyone. I'm pleased to be here, and hopefully this will be able to shed a little light on IT outages in healthcare for your preparation at your facilities. So when we think about IT outages and healthcare operations and patient care delivery, I think, obviously there are two things. Like, is it an electronic downtime or applications failure, or is it a cybersecurity issue, right? And those are two very separate things that I think we want to dive into a little bit here. Obviously, there's significant IT investment to drive innovation and improve operations. I think that also leads to adopting advanced technologies like AI and other automation in healthcare. But when that doesn't work, right, when we do have a failure, how do we handle that? The efficiencies that are gained, through technology in healthcare operations definitely improve workflows, improve our ability to communicate faster, quicker, and in ways that we haven't been able to do prior to having electronic medical records, prior to having some of these automated systems. And also, if we just think within the last, say, decade, where we have the ability to function now in medicine off of our mobile devices, right? So before, everybody was tied to, a hard computer or hard drive computer that was on the network. Now we're able to get it on our iPhones or Androids. When these things are non-functional, and especially for people that are new to medicine, there is a gap, right? There's a gap in the ability to revert back to a time when you didn't have these things in place, right? When it was faxes and phone calls and paperwork. And I think that is a challenge. It's a real challenge for our new nursing personnel. It's a new challenge for residents, medical students, fellows, people that are recently engaged in healthcare, and that inability to have those kind of old school skill sets can lead to gaps in communication and potential, risk for patient harm, right? If we don't have the right communication, if we don't have the right workflow for how a patient is going to move throughout the continuum of healthcare, we can, potentially set ourselves up for some risk there, right? So when we think about IT outages as a whole, if it's an application failure, if it's an EMR failure, some of the best time for those things to happen really truly are like the night shift, right? So, when we think about our night shift, it's when all of our upgrades occur, right? So we're constantly in that mode of training and practicing in downtime mode, and right, so they have the repetition to do it well. When it happens during the day, when we've got all of our outpatient business, we've got all of our surgical cases going, we've got our deliveries going, that really puts a wrench into the workflow and a wrench into the system of healthcare as it is today. So when I think about those IT outages from a broad impact or broad perspective, it really disrupts the everyday workflow that we've all become accustomed to because we're so dependent upon that technology. And then when we also look at like cybersecurity threats, that's a completely separate, different problem that some healthcare systems have experienced. I think we've all read in Becker's over the last 3 to 5 years the increasing number of these incidents that are occurring where essentially you're being held for a ransom. It may be Bitcoin, it may be a transfer of money. They're holding patient information and records, but they're also holding your ability to care for your patients, right? The ability for you to communicate internally. And sometimes externally with external entities. And so that too, I think, is a disruption that you have to be aware of, you have to plan for, and you have to train for all of these things, right? It's definitely a risk. It's definitely an opportunity, and I think we'll hear from Sage later about how do we drill these things? What do we do? And we also look at those real life instances where we have these things occur. And what do we learn from those? How do we get better each time that these things happen? So that's just some broad impacts that that we see in healthcare operations and patient care delivery around IT outages.
Thank you, Matt. So you brought a few things that I would love to expand a little bit further on. So first of all, the example that you gave about the cybersecurity and how some hackers might be asking for Bitcoin or might be asking for that. That's actually a scenario that we study in the IT course, and we let students go through that exercise. You mentioned a few things or a few buzzwords. You said there would be risk for the institution, but also you gave the example on how the night shift might be different from the day shift in the response to those outages, or how they are impacted by it. But how do prolonged IT outages pose financial, legal, and reputational risks for healthcare organizations from your perspective?
Yeah, I think over the last several years we've had more concerning reports of these prolonged outages really on the rise, right? So these are, what are the consequences of a digital system downtime? So information technology and application failures definitely play a role in, potential patient harm. And so that opens up the organization to risk and liability. And so the financial reputational risks are there. If you have, a significant business impact around prolonged interruption in services, I mean, that can have a lasting effect on the organization. We think about how patients choose you. I mean, they're choosing you based off of your ability to provide care. If it's your first interaction with a patient or a first interaction with a physician that's an independent, that doesn't utilize your system, and you're having an IT outage, or you're having prolonged downtime, or you're having system failures, obviously that can lead to reputational impact. But there's definite liability, right? Definite liability from a risk standpoint around patient safety if you're unable to communicate effectively around the care necessary to provide safe, high quality patient care. So again, definite reputational risks around prolonged outages.
And Matt, from a leadership perspective as a chief operating officer, when you hear or when you get the update or the debrief that there's an outage, an IT outage, what are the key areas of concerns and focus that comes to your mind right away? What would you do first thing?
Yeah, so obviously the first thing that we look at is just try to gather as much information about the incident as we can, right? When we first are getting the information, it can sometimes be broken or fragmented. So we want to collect all the information that we can so that we can really digest that and then communicate effectively. So I would say the most important thing you can do in an IT outage that's going to last any significant period of time is communication, right? Whether that's with an Everbridge system, a mass communication tool like Alert Media or Everbridge, where there's an incident command call that needs to be set up. We need to be able to have bi-directional communication. So we need to be able to get the message out about what's occurring and have it be factual with I think appropriate ETAs around downtimes if we have that information. And then we also need to be able to gather information from the front line around what are they seeing, what's occurring, what's happening on each individual unit, each department, and then how can we assist? What's the best pathway forward? Typically, we end up with a bridge call, right, with our system IT. And so the incident command at each facility organization will be able to have a direct line to, a bridge call with the system IT incident command. So we're getting that communication. They're hearing from us, we're hearing from them, and we're able to relay that back to the front lines. I think that's really important, right? People want to know what's going on, when the issue can be resolved, so then they go back to normal operations. And if their normal operations are going to be disrupted for, again, that prolonged period of time, we're putting into place workarounds, plan Bs. How do we ensure that we don't miss anything or create any, undue risk for patient harm?
So Matt, you said communication, and here it comes to my mind, when or if would you communicate that to the public that we are experiencing such difficulties? Mm-hmm. Would you do that? And if you do, when?
Yeah. So, typically what we'll do is we'll engage our PR and marketing team, right? Anytime we're going to see something that is going to impact or have the potential to impact patient care, we want to ensure that the public also knows about it as well, right? Because they can help us. And so usually it's around the first few hours, right? If we know that we're going to have a significant impact, that we're going to have downtime, it's going to be within a few hours that we're having those conversations about releasing a statement, trying to, at the same time, I think, ensure that we've got the right communication, not to, disrupt or upset the general public, but at the same time, we don't want to steer anybody away from coming to the emergency room, right? That may need it or may need, emergency services. But at the same time, if we know that outpatient services are going to be disrupted for a period of time, we want to be able to help offset that workload. And so being able to communicate effectively with the general public is important in these instances as well.
No, thank you for answering this question. So maybe now I will move to Sage as the Director of Emergency Management. Maybe some of the audience do not know exactly what emergency management mean, and some people, I've experienced this before, they mix it between the emergency department. So could you please just brief us or educate us a little bit about what does emergency management mean in the setting of a hospital?
Absolutely, sure. Thank you, Basel, and thank you for having us here. I think this is going to be very valuable. I mean, it already is for me. Hearing from Matt, I'm excited to hear his perspective on IT downtimes as well. Not that we don't hear it when we have our own downtimes, but to your question about emergency management, well, emergency management really is, in my eyes, bringing order to the chaos. And there is no shortage of chaos in hospitals. Really, when I think about it, I like to use the analogy of the heartbeat line on the cardiac monitor of hospitals operating. It has its ups and downs on a day-to-day basis. There's some hiccups that occur where it throws operations through a little bit of a tizzy, but nothing that can't be handled usually internally. It's when something goes way up here. It's a real weird rhythm that really throws us out of whack. That's when I get activated generally. It's something impacting hospital operations, either in a way that is negative to the safety or well-being of staff, patients, or visitors, or negative to the business operations that we're trying to accomplish. So how I look at my job and how I look at thinking about these hiccups is we think about it from the emergency management, the levels. You want to plan for any event. And at Winchester Hospital, we have what's called an emergency operations plan that is all hazards, that is encompassing of what we would do during any type of disaster, let alone just an IT disaster. But it just gives us the blueprints of what we as an organization think when we want to operationalize our incident management team. So we think about it from a planning perspective, but then we think about it from a mitigation perspective. So my job, especially with IT downtime, is how can we mitigate the effects of downtime? Because as Matt very well put, there's a lot of very significant impacts that could occur throughout the organization. So I'm not directly creating downtime forms. That's not my role, but my role is to ideally help individuals have easy access to them, potentially drill them, think about when the next downtime is going to be, and think about different types of downtimes, because there are a lot of different types of downtimes that could affect the organization. I know we talked about two, the epic downtime, or what we were talking about with CrowdStrike or some sort of cybersecurity. But when you think about downtime in a hospital, there are a lot of different things that could go down from an IT perspective. So there are conversely a lot of ways that we can mitigate the effects of those types of downtimes. Then ideally, we have a good plan in place, some good mitigation strategies. Of course, it's going to happen. So I respond to those types of events as well, and I help guide that response. I would say I fall short of lead, because I am at the side of the incident commander, ideally in the situation, trying to guide in best practices with respect to emergency management. And then ultimately, after we recover, or after we respond, we recover to these types of events. And recovery, as I'm sure we'll get into much more in depth, is really a very, very significant process after the downtime's actually been completed.
See. So Sage, you said, preparing and, you said mitigating also, and we will go into that. But what are, or how does your department help in preparing for the IT downtimes? I know you mentioned that we have protocols, and I think that's typical for every hospital. But what are the primary responsibilities during such an incident when it happens?
Sure.
Also that you carry.
That's a great question. Honestly, a huge percentage of what I do from a response perspective is unachievable without the support of leadership in the hospital. Not just leadership, but the boots on the ground, the people who are actually doing what needs to be done during downtime. And none of that really works without prior engagement with the key stakeholders in that type of an event. So honestly, IT is really the perfect example of having to build a partnership between key stakeholders, which is really ends up being a lot of what I do. A lot of what I do is bringing the right people into the room to solve the problem that's in front of us. So you will never catch me saying the IT department doesn't know what they're doing, because quite frankly, I have, generally speaking, no idea what they're doing most of the time. But if we take CrowdStrike as a good example, I wasn't there that day. I was away on vacation. I was in the Catskills, but I was on my PC at 1 a.m. trying to help the hospitals that I'm responsible for respond to this event. We have, prior to that, I'd say an innumerable number of IT downtimes that had already occurred. And what ends up happening with those downtimes and any event that we face in the organization is that we generate what's called an after-action report. And an after-action report is where we get all the key stakeholders together after an event has occurred, and we talk about what went well and what didn't go well. And from those after-action reports, we build action plans on how we can improve our response moving forward. And Matt made mention of the bridge call that IT puts together. It's actually called their major incident management process. That was the result of downtime, probably, I don't know, maybe 2002, that they thought, okay, we need to come together as a system. And then it was after subsequent downtimes that they realized, all right, you know what, this is a good process that we have, IT coming together, figuring out these issues, but we need to bring emergency management into the fold. We need to bring communications. We need to bring local hospital leadership. And I'm really glad that Matt brought that up, because that is a direct result of us, emergency management leadership, working with IT to say, hey, we know that you are going through some operational changes, some changes in structure. We just need to be at the hip with you so that we're never off of the same page. And I really appreciate that process in emergency management, because it's never ending. We're always trying to improve in what we're doing. And honestly, it seems like a silly thing for me to sit here and say that we implemented this process, and it sounds like, oh wow, that's actually kind of a very straightforward, like, why didn't you have that process to begin with? But honestly, it's so much more complicated than that. And I can always sit here and play armchair quarterback. Honestly, that's almost what I'm paid to do, is to be the armchair quarterback. But it's my responsibility then to take that and do something with it, to say, all right, well, you know what, maybe we could have done this better. We're not pointing any fingers. So let's see how we can do that, how we can implement that, how we can improve that.
So basically, correct me if I'm wrong, but I'm making this correlation. So you have the post incident action plan, but also you have your preparedness plan before.
Mm-hmm.
So I assume the more prepared you are, the less extensive your post action plan will be, because you would have run through drills and people know exactly what's gonna happen during the emergency based on their training. So can you speak a little bit to what makes a good preparedness, a good an effective downtime protocol, particularly in terms of communication, coordination, ensuring continuity of care? What does a good plan look to you?
Absolutely. Honestly, Matt was stealing my thunder. He was going right into it. It was like music to my ears, because he serves as one of our administrators on call. And would be the incident commander in one of these situations. But really, at the onset of any event is really determining that information. And I won't dive into it. It's really the who, what, where, when, and why. So who is impacted? What is impacted? What systems are impacted? Why is this occurring? That it gets us into the is this a cyber incident? Is this just an incident because somebody bumped into a wire and it took out all of our telephones? That's something that has actually happened. And then when I guess with the what, that really drives also. So what is happening? What is down? That kind of tells us, all right, it informs what downtime procedures we need to put in place, because not every department needs to go on downtime every single time. So if it's Epic, for instance, that's going down, that is our electronic medical record. That usually will result in some very significant downtime procedures. But on the opposite hand, if it's Kronos, our timekeeping, that there are downtime procedures that would need to go and be put in place for that, but it's much less significantly impactful. So I would say knowing what's going on is absolutely crucial. And it's easy to point to those big, I call them the sexy events, the electronic medical record being down, Wi-Fi being down, telephones being down. But it's a lot more difficult for us to understand what's going on when it's IT telling us it's the Citrix receiver that's down, or it's some external vendor that you've never heard of that we just bought into last week that's down. It's those situations that really make it difficult to make decisions in incident command. So then I say we pulled together the incident management team, incident command. Usually it's just a couple of us, at least initially. And first and foremost, our goal is always patient safety, patient care, staff safety, staff care, visitor safety, visitor care. And with that in mind, that's how we generally tend to run our incident management teams. Is we think, okay, well, we talk to the group, we explain, as Matt said, what's going on and what are we doing about it. And then you asked about communications. We certainly work with our communications department. So not only are we communicating internally within our own incident management team, but we're trying to get a communication out as quickly as possible to all staff to let what they should be doing about it. Usually there's not enough information to go off of in the early parts of an event, but that's the ideal. That's the best practice. So we do utilize downtime forms. So one of the things that we have in our repertoire, and I won't get into the nitty gritty of the downtime forms. Again, I'm not responsible for developing the downtime forms. There are people who are much smarter than me who do that, but we make sure that we have enough of those, or we make sure that people know that they have to utilize those. We have what's called business continuity access computers, BCA PCs, which take a snapshot of patient information basically at the time that the system went down. That it's a view only, but it's such critical information that staff can use to help facilitate the patient care process. We have to go into a very, very manual process of communication between inpatient floors and all of our ancillary services. So this is where it gets very complicated and really starts to slow the wheels of delivering care. Is all of a sudden when you could put in an order for a lab or to the pharmacy or to radiology, that all of a sudden becomes either a fax or a phone call, or we change practice and we say only critical results for this type of patient. It gets complicated. It gets complicated very quickly, but we fall back to our practiced events, so events that have taken place, and then we fall back onto our emergency operations plan, which it creates a governance structure that is not dissimilar to how the hospital normally operates, but it provides for one person who's making, at the end of the day, the ultimate decision on what we're doing moving forward for it.
And Sage, I would imagine depending on the hospital, there would be different, some variations with the preparedness plans. But do you feel that, based on your experience and work through different hospitals, that the plans are usually similar, or there are major differences based on the criteria of each organization?
That's a good question. I would say that at least within the Beth Israel Lahey Health Network, because we have a systematized IT service model, that a lot of what you would see in terms of downtime would be similar across all the organizations, at least from a system perspective. From a local emergency management perspective, because we all operate under the Hospital Incident Command System HICS-4 guidance, I would say that our emergency response would also look very similar from institution to institution. Now, what it specifically says in the EOP, whether they have different checklists than us, that might be where you see some differing priorities potentially. So Winchester, for instance, isn't a level 1 trauma center. It's not going to have necessarily the same priorities as what BIDMC in Boston would. But that doesn't mean that we are not looking at the incident from a holistic approach in the same way that they would be. It's just that there might be different priorities.
Well, thank you. So now I'm going to shift gears a little bit to go more into the boots on the grounds and move from the leadership and the incident command center, the emergency preparedness and management, to what is happening actually on the floors, and also what's happening within the IT and the informatics team. So Julie, I'm gonna now ask you a few questions, if that's okay. But can you please start by providing us with some information on what does an informatics department mean in the setting of a hospital?
Sure. Thanks, Basel. Thanks for having me tonight. I'm really grateful to be here with you all. So at Winchester, we are fortunate to have a nursing informatics department. So there's a total of 4 of us. We have 3 nursing informatics specialists and myself as the nursing informatics manager. We are all nurses. Our title says nursing, but we support much beyond the role of a nurse. And really, I would say the majority of our time is spent at the hospital, out on the units, working with staff. So that includes rounding on all of the units, really checking in on, what is going on day to day. Is there issues? Are there questions? Things like that. So it really depends on, are there, Epic related EHR issues? Are there other IT related issues? For example, this week we've had some printer issues. Today we had some device issues. So, things that are not just, something that you would see within nursing. Oftentimes we're doing at the elbow support. We're doing in real time education on documentation with some new assessments. We also work with, our nurse managers and leaders and educators. We work with, and that's not just in the walls of our organization. We're also working with our colleagues throughout the system. We're doing classes for that. So it's hard to really kind of just describe one thing that we're doing. I feel like oftentimes we have our hands and feet in multiple areas for what we support and cover. And I do think we have a great team. Sorry to interrupt, but we all are nurses. We all have clinical nursing as our background, but we all come with a different background. Each of us really, our bedside nursing areas of focus is very different. So I think that makes us a very well-rounded team to be able to support all of the different areas.
No, thank you, Julia. So oftentimes what I find from students asking, when I ask them about their understanding of the informatics department, they usually say, well, it's the department that run reports or generate reports. And that's usually what the common answer that I receive. But thank you for explaining that it goes way beyond that. So going back to the downtime and the IT outage, how does a hospital's informatics team plan and respond for an IT outage? Do you have different plans, or do you coordinate with the emergency preparedness team, or do you have your own plan? What does a day like that look like for you?
Sure. So I think some of the words that both Matt and Sage have spoken about are things that I have, was thinking about. So I think when we think of downtimes or outages, we kind of look at 2 paths. We look at the path of there's a planned outage that we know that we're going to have our Epic planned downtime, and we know it's going to be down. We do it overnight, usually on a weekend, usually less patients, less staff there, and those are scheduled. So we have a little bit more control over those. And then you have the other path where they're the unplanned downtime. So, unexpected, what do we need to do? So in thinking of those, so in preparing for staff are scheduled or planned downtime, we usually know what changes are going to be coming. We know the date and the time that it's going to be happening, and we've communicated out. So for us, we will communicate that out via email. We'll communicate it out through our safety huddle, get the information out to everyone, what's going to be down, coordinate with other departments. So for example, when we're going to have a scheduled downtime, we actually put our Pyxis machines with our med dispensing machines on critical override. So we need to engage pharmacy, who also needs to, set the time for a little bit before the scheduled downtime to a little bit after. We need to work with IT to make sure that everything's kind of in line of when they're going to, definitely have the downtime. So there's lots of parties involved, really in just the planning of that. And historically, we've had those done about quarterly. So we do have them. So I feel like it is where it is a night, it is usually a weekend. We do, the same staff tend to usually be working often, so they do get comfortable with it. Some of the things we've learned more recently is we have a younger staff across all disciplines. They do not know what a paper record is. They don't know how to document on a paper chart, how to write paper orders. So I've actually had to do some re-education with that, put together packets, put together binders on the units that are resources for them. As Sage mentioned, we do also have on every unit or department, BCA, a business continuity access computer. Those are downtime computers. They are all labeled. Even some of the things we've changed over the years from the IT side with those. Years ago, those computers used to almost be like in a office that was locked. The computers were not used. Now we actually have them out in the, the main unit. They want to be used often. We want to make sure that they're running. And we are able to get reports off of those until the time that the system goes down. So those are some of the things that we do have. And then for the unplanned downtimes, unfortunately, it's usually really just taking into account what's going on. What is the impact? Is this one unit, all units? What is down, what's up, what's down, really, start with taking an assessment overall of what's going on to really help drive what we need to work on, and work with our colleagues, leadership, IT, to really help drive. So at that time, in addition to just learning what's going on, is really just supporting the staff and making sure that they have what they need.
So Julie, in unplanned outages, are there specific departments that you would prioritize in helping over other departments?
So I guess when I think back to July in the CrowdStrike, it was early morning. So it was mostly focused on, at the main hospital, and really just the assessment started with, is this everywhere? And, for us, it was not every device that did go down. So then staff were, utilizing the devices that were still up. So that was just really trying to take an assessment, early that morning of, what was down, what was up, because we really still didn't have a plan at that point. So I think a lot of it is just really, checking in with the staff, doing the assessment, and really making a plan. So, and then it's really depending on what the downtime or the outage is, it really starts with IT. And, as we've mentioned, some of the incident command calls and really kind of diving into what is going on and causing the outage.
See, and Julie, does your team also play a role after the outage happened and after we have passed this challenging time? Does your department play a role in anything in the next preparedness, or do you play a role in the recovery plan, or your function is mainly actually during the outage?
No, so I can just think back to July specifically, and we were in and on the ground, really just kind of helping every way that we can, updating the system as we were learning from IT what needed to be done. And then kind of following once that, was resolved within, the beginning of the next week, we did take a time, we did debrief internally with the group of us to really talk through like what, the challenges and what went well. And then I was able to sit down with the group of leadership team and bring forward some of what my team had felt. And we did discuss as part of the debrief afterwards. And then what Sage was mentioning with the after action plan for that. I think the other part that's nice to say is we do have colleagues at other organizations. So we were able to be in contact that weekend to see, check in with each other, make sure, see how things were working at our, other systems, other organizations within the system, to see if everybody, was feeling okay and to kind of check in. But I definitely think throughout the whole time. The biggest thing that I would say that is most helpful is the teamwork part.
Thank you. And speaking about the teamwork, I think it's now that's a nice segue to go and to Brandon, ask him, as he leads the med surg area in Winchester Hospital, and he's the nursing director for that. So Brandon, can you speak a little bit about what are some of the specific challenges that clinical teams on an inpatient floor faces during an IT outage from a nursing perspective, and how do these challenges affect your daily operations?
Yeah, thank you, Basil. I think, if I may, I want to expound a little bit on what Julie mentioned with the paper MARs and kind of how we got to the point in healthcare where we've gone electronic. So in the early 90s, I think 1999, the Institute of Medicine came out with a report to Err is Human, attributing over 19% of adverse patient events, over almost 98,000 deaths, to healthcare-related issues. So after that, Congress passed legislation to really push efficiency, safety, and quality with the adoption of electronic medical records. And so I can remember early on in my career in the early 2000s using paper MARs and thinking at the time of like how difficult it was to like bring the paper into the room, to know like what you had to give without making a mistake. And when we early adopted the electronic scanning, all of these different devices, it really was a game changer to make sure that like you had the right barcode, you had the right medication, the dose is double checked, and it put in place like additional safety mechanisms to really elevate the role of the care team. Pharmacy became more centrally involved, like on some of the floors of some of the hospitals, they moved them to the floors. And then you had like whole changes in workflows attributed to this. So really over the last 20 years since that report came out, it's really revolutionized healthcare. So during outages, as Julie kind of mentioned, I think Sage alluded to a little bit as well, like it depends on the extent of the impact, because I think we fail to appreciate like all of the safety mechanisms that have been put in place as a result of that report. And as a result of just all these errors that we've identified throughout healthcare, throughout other industries over the years. So a downtime impacting telemetry, for example, where we lose central monitors can be very, very different and require like a different set of safety protocols than one that impacts our electronic medical record. And something even as seemingly simple as a telephone can completely ground operations to a halt if you can't coordinate care between departments and admissions and get patients off to testing. So one of my focuses, and especially during this outage in general, is to really bring the paradigm, like really speak about like, what do we have to do to provide safe care at any one time and maintain the same level of efficiency and safety that we have as we did like before the outage. And that really comes to whether or not it's planned versus that cybersecurity event that it's unplanned event. So as Julie kind of mentioned, with the planned downtime, it's very, very easy. We have procedures, we print the MARs, we really instruct the nurses, even though they might not use those often, how to make sure that everything is validated, correct, the right dose. With the CrowdStrike situation, similar to Julie, we were all in here very, very early, rounding in the hospital. And like, to me, it's maintaining continuity of operations using what we have for devices or communication. So it's making sure we validated what the orders are supposed to be. We did use, so to me, the computers are our safest double check. It's scanning the meds, it's validating the patient. We did have computers that were working. We wanted to use those whenever possible and make sure we had a good seamless way for nurses to check the medications before they went in the rooms. But then it's really going back to really basics and really emphasizing like good practice of like double checking the dose, looking at the package, verifying the patient's armband, like all of these safety practices that we put in place prior to the adoption of medical records that we should still be doing, but really taking the extra step further to really validate that everything is done exactly as it should. And then the communication piece. So including the testing departments and figuring out like how you're going to communicate if the phones are down. There's been times when we've had the phones down that we've handed cell phones out to various clinical departments just to make sure that those important phone calls can continue, because otherwise we could interrupt patient care. So to me, it's really just bringing back to basics as to what we do every day so everyone understands the choices they make and how they impact the general safety of the patient.
So Brandon, you focused on the communication, and here I'm going to ask you, during a downtime where everything is hectic and you do not want that hectic feeling to move into the staff on the local level and also not trickle down to the patients. So how do you manage the communication directly with the staff at that time, knowing that your methods of communication might be disrupted? The emails, people are, as you said, they're going to be like doing paper forms. Nobody's going to check their emails. It might be impacted. Nobody's going to communicate through the electronic medical records. If there's critical information, what do you do? How do you communicate? How do you communicate with your staff, and how do staff communicate with each other during such times?
Yeah, so again, I think it matters whether or not it's planned versus unplanned. But in either event, clear communication, presence with the staff, and just override, given kind of the goal of what you're supposed to achieve and what you're doing, I think is just paramount. So to me, like when we have these planned downtimes, we often focus on making sure that staff know how to access the forms, how to get to everything they need to. If they have questions before the start of the shift, we do late night huddles just to make sure that everyone's kind of on the same page. And we make sure that we have a key person who's the nursing supervisor that carries the message of like what they need to do. So that way everyone has a point person to go to that's visible, that's in a leadership position that everyone can go to with any questions and they'll have the answer. Now, with the unplanned downtime, as Sage had mentioned, we go to a command center model where we have one person making the decisions of what is going to happen and how we can maintain operations to the best safety measures possible. And really, when that happens, it's us carrying the message to each of the floors to the staff about what the process is that we're doing and making sure that if they have any questions that we can quickly get those questions to the command center to be answered, to be resolved in real time as soon as possible for the staff.
So Brandon, from an administrative and perspective, in relation to the staffing, in such a downtime, would you start calling nursing and staff to come in, or would you avoid such thing, or is it case dependent?
It's really case dependent. I mean, so I think the extent of, so sometimes it can be disruptive, right? If you're trying to bring in a bunch of different staff into an organization when the systems are already kind of stretched beyond their limits. That can be an additional variable in there that can actually make it a little bit more difficult to kind of manage the operations. That being said, you want to make sure that you have the right people there in the building for support staff and help. And so then you start seeing like other leaders come in. You see IT, you see informatics. So we make sure that we have the right complement of other leaders and other departments to support the key staff, the core staff, but it's really resolving the issues that kind of come up. So for example, like if we have an issue and our telemetry goes down and we have no more central monitor capabilities, those patients still need to be monitored for their heart to make sure that they're not having arrhythmias that could prove fatal. So the situation of how we handle that is going to be very, very different. It's going to be making sure we get bedside monitors in the room, that we have staff available to train them, that we call our vendor in to come look at how to reactivate the system. And so we're bringing in kind of the specialist for those sorts of situations, as opposed to just like bringing in like general staff to kind of help. I mean, sometimes we might bring additional pair of hands in, but it's really bringing the specialist to that we need to resolve the issue at hand.
And also another point that was raised is the experience of the nursing staff. Some of the junior staff probably have not used paper forms before. From a nursing culture perspective and departments, local culture for the department, do you see a difference in that? Do you feel that more junior nursing are less comfortable in such events and more senior are comfortable? That would be my assumption. How would you go around reassuring the staff who are not used to such incidents in such cases?
Yeah, so in Epic, we put a lot of safety mechanisms in place to make sure that the nurses can do the right thing in terms of if there's hold perimeters, if you're not supposed to give a certain medication, heparin calculators to make sure you're giving the dose correctly, instructions on labs you need to check before you give those medications, and vice versa. So without those electronic safeguards in place, you're really left to read the instructions, find the data, interpret it, and make sure that you're doing the right thing at the time, which used to be second nature to a lot of nurses when you would use paper Mars. But when you're just on paper and you've never learned any other ways, it's easy to do that. But when you convert to the electronic piece and you've used that for some time, you really have to give everyone pause to make sure that they read each instruction very, very detailed. They know where to find it and that they understand the why. So, if you're holding a medication because of a lab, you have to know where to find the downtime information to look at that lab before you get that medication. If you can't use the heparin calculator, you have to look at the worksheets that instruct you about how to adjust the medication to make sure you're still given the right dose. So those are different skills that we really have to reassure the nurses that they're doing the right thing. And the informatics team is great because they can kind of direct the nurses to how to do those resources. And other times we pull in education too, because they can direct the staff on how to interpret those values and use those MARs or interpret the labs based on the situation at hand.
And again, it goes back to the preparations and all that. But do you think, from a practical perspective, Brandon, that prolonged IT outages might impact the patient safety despite all the measures that you have? Do you think the incidents might increase during that?
Yeah, I think as a system and as a healthcare organization, we do everything we can to kind of mitigate those impacts. And I think we've been very good at making sure that we put in additional safety mechanisms and in place really during the short term, because the expectation and goals are always to get the IT systems back in place as soon as possible, because we know that there's value in these double checks, these scannings, the coordination of the care with everyone reading the same records and everything. So I think to me, like the sooner we can get everything online, the better. But I think in the short term, I think one thing we've done very, very well is making sure that we have the safety mechanisms in place so that we don't have adverse outcomes when things go down for these short windows of time.
So I'm just going to be mindful of the time that we are almost at time. So I will take a couple of questions. So maybe this is a good question. So from the audience, and so please share your message view through the message through the text message here on Zoom. But I have a couple of questions here. Maybe one of them is for Matt. Matt, one of the audience asked, how long can a hospital realistically operate during an IT outage before patient care is significantly impacted?
So, Basel, I would say definitely, right? I mean, we would work through all of our downtime procedures and protocols, right? And I see there's a secondary question on there about how often they're reviewed. So typically reviewed at least annually at a minimum. And then if we have any changes to workflow or changes to protocols or processes, then those downtime procedures are then updated and then staff educated. But our goal would be to run, indefinitely to be able to provide care, right? We're still going to have patients that are coming to see us for emergency room care and for X-rays, CTs, MRIs, for cancer care. All of those things would have to continue regardless of our ability, to be able to utilize our electronic medical system. So we would have to go essentially back to the old school way of a paper process. And phone calls and faxes. And if telecom was down, then, it would probably be, Pony Express, I guess. I don't know what we would do in that instance, but we would find a way to take good care of our patients and do it in a way that, provided safe, high quality care. I think that ideally, to Brandon's point earlier, right, we look to the enhancement of IT and electronic, medical record systems and applications to improve the level of care that we can provide in a timely way. But that doesn't stop us from being able to provide the care that we should in order to ensure that we have that high quality, safe patient care, even in the event that we had a prolonged outage. Now, I think if we were to get into a situation where it would be weeks and weeks, obviously, there'd be a lot of plan Bs that we'd have to put into place, right? We'd probably have to reduce the amount of outpatient, work that we do. We'd have to be more focused on urgent and emergent care than we would be on elective care. So I think there are things that we would have to prioritize, but we'd still continue to provide care to patients as they needed it, as they came to see us and sought care.
And one thing it strikes me, And I keep thinking about, while we are discussing this, is that we are such in a luxurious situation in which we have electronic health records. We have informatics departments. We have IT functions that we can function on. That is not the case in other parts of the world. Even in Europe, in which we typically compare the healthcare system in the United States to Europe. A lot of the countries in Europe, they do not have that. I know I have some colleagues who practice in Germany, for example, not to say a negative thing about that, but a lot of the hospitals do not have electronic health records. So this is a problem. This is a day-to-day problem for them. There's actually a question that came from Terence to Sage. Sage, after an unexpected significant downtime event, what is the procedure for you and your team when it comes to modifying or creating a new contingency plan? Are you able to simulate and test contingency plans to gather data and practice implementation?
So I guess in the immediate sense, what I alluded to earlier with our all hazards plan, if it was something that was truly unique, I would say that we have a really good system to be able to turn on a swivel if we needed to respond to whatever the event was. And I do tend to fall back on this anecdote of an emergency isn't like baking a cake where you put in all the ingredients and you expect the same result. Honestly, no two emergencies, even if they are the exact same kind of downtime, will ever complete or have the same kind of impacts. You can generally create and think about some similarities, but I would say just specifically to your question in terms of contingency planning in the immediate moment, we would look back at prior after action reports to get an understanding of what systems might be impacted and move forward with that information. As far as simulating these contingency plans, that is something that we are actively working on with. So our system, our Beth Israel Lahey Health System, is rolling out Epic as an electronic medical record system across the entire of all of our hospitals and support services. And something that we are looking to do actually is to test our plans in different ways, in different types of downtimes, to see how the system operates differently depending upon what the kind of kind of downtime is, whether it's malicious intent, whether it's caused by a separate utility downtime like the electricity going out, right? That could knock out our Wi-Fi. So just thinking about it in that way. We try to simulate as best. There are a lot of different types of emergencies, and as much as I would love to test and practice IT downtime, there's a lot of other things that we also have to prioritize in terms of being prepared for. So I would say that yes and no to your question.
Thank you, Sage. So it is 7:58. So we have only a couple of minutes, and so I don't see other questions. So I'm gonna ask, would any of you would be willing to share takeaway points from this conversation? What do you think are the most important things for the audience to learn from this conversation? I can guess, but I would love to listen to your input.
So Basil, I would just say this. I would say, when we think about healthcare and IT downtimes, I would think, if we were to take away anything, that health systems are very focused on this, right? And we're focused on it because we do understand the impact for this to potentially affect, patient care or could create patient harm. And so just know that, not only is Beth Israel Lahey Health very focused on ensuring that we maintain operations so that we can provide that timely, high quality care, but so are every other health system, right? M.G.B. is doing it, Tufts is doing it, Bay State's doing it, and all across the country. You've got teams of people like Sage and, Brandon, myself, and Julie that are supporting these downtime efforts when they do occur. And so that we're able to continue that operation, continue to provide that high quality, timely care to our patients.
Thank you, Matt. So we are at time, so I'm gonna conclude by thanking the audience for being here. If you have any questions, please feel free to email me directly. My email is tarab@bc.edu. And I'm really grateful for all the panelists. I'm really proud for working in a great hospital like Winchester Hospital, where I can rely on my leaders and colleagues to come and share their expertise with the students at BC. So thank you so much, Matt, Julie, Brandon, and Sage, and have a great night.
Thank you.
Thank you.
Thank you.
Bye.